Hello, this is John Kanelopoulos on behalf of our investigative team by Vaso Mustu, optometrist, George Melis, PhD, and myself from the LaserVision Clinical Research Institute in Athens. I'm pleased to present to you a comparative evaluation of Sutureless decimate stripping and endothelial keratoplasty employing a polyethylene glycol-based ocular tissue adhesive, ResureDSEAKRv-16309, standard procedure, which was when we used nylon sutures to secure the wound. Stripping Decimus membrane and loading the graft on the Busson spatula, and then inserted in the anterior chamber with a retina forceps. The graft is in the anterior chamber. We're waiting for it to unfold with irrigation and folds in place, secured with a gas bubble. And here Resure is applied on the large incision and the prosthesis seen here. A great stabilizer for potential suture placement, and here an excellent result a few months later. Thank you. In these 35 consecutive DSEAK cases, we evaluated retrospectively. In the first group, Group A, 15 eyes, the use of a tissue adhesive, Resure, made in the US and CE marked for many years now. While in Group B, 20 eyes, we used our traditional technique where 2 or more nylon sutures were employed to secure the cornea incisions after the bubbling of the anterior chamber in order to attach the DSEAK graft on the posterior surface of the cornea. The perioperative complications were noted and compared. Visual acuity, refraction, topographic cylinder, intraocular pressure, and endothelial cell counts were monitored long-term up to 2 years. Follow-up time for this case series were 10.5 months, plus minus 8.5, so anywhere from 1 to 2 years. No case from the Resure group required additional air insertion following the tissue adhesive application, as you saw in the short video shown in slide 2, and no case required additional intraoperative surgical manipulation for further graft centration. The story was different in Group 2, the group that we did not use Resure. 18 of 20 eyes required that we supplemented air because with suture removal there was some inadvertent air escape from the wound, and 4 of the 18 eyes required supplemental air, required intraoperative repositioning of the graft. The differences between visual acuity and intraocular pressure were not significant between the two groups. There was, though, a significant difference in endothelial cell density, with less loss in the Resure group than the suture group. That was statistically significant. We noted a hyperopic shift refraction-wise in both groups, and there was no significant cylinder difference between the two groups. There was some reduction of cylinder since we always chose the incision to be in the steeper axis. So as far as the cell density, the Group A Resure group performed much better. The polyethylene glycol polymers are also materials considered for wound healing. They're biocompatible, and they're also used for many years in hydrogel contact lenses and wetting agent applications. The way we apply this particular product, as shown in the video in slide 2, is painted over the wound, and what's very nice clinical is that it polymerizes very fast in less than half a minute, and it creates a soft form of bluish ocular surface, kind of a bandage over the incision that usually melts away the first or second day postoperatively. There's 2 such products available, Resure and Ocular, and they have had a history in used in limbo conjunctival wound surgical technique after trabeculectomy, after cataract surgery, after pterygium surgery, and for amniotic membrane placement. This, to the best of our knowledge, is the first peer-reviewed report of using it in DSEAK cases. We did see a hyperopic shift in all of our cases, about 2.5 diopters in the 1-year interval that we evaluated. And this is obviously one of the disadvantages of DSEAK, especially if it cannot be combined with intraocular lens implantation, where this fudge factor can be counteracted with the appropriate IOL choice. The refractive change obviously has been attributed to the lenticular nature of the DSEAK graft when it's created with microkeratome. The application of ResureDSEAKRv appears to be very safe. It was very easy to do intraoperatively, and it seems that it significantly improved surgical outcomes. So we have since incorporated in our routine DSEAK cases. We find that the actual take-home message from the study is the fact that after placement, centration, and bubbling the anterior chamber with air, placing the ResureDSEAKRv over the main incision and the paracentesis where the graft is pulled through with the retina forceps reduces the chance of losing that air bubble and increases the very critical for the first hour stable anterior chamber. Now the surgeon has the option to place sutures even through this ocular bandage, and we've done subsequently in some cases just for safety reason, but the great advantage is during that suture placement no air will leak out, and will probably be no need to rebubble the anterior chamber, so less graft manipulation, less possibility for graft slippage, and better endothelial cell counts. So in conclusion, we report the first such case series with the use of ResureDSEAKRv as an adjunct in successful clear cornea DSEAK surgery. And by comparing these two groups, we found that the ResureDSEAKRv cases performed better than the ones that only sutures were used, potentially due to the reduction in wound leak and rebubbling and repositioning of the graft. And these cases also should be noted carry potential additional advantage of less chances for a infection due to wound ingress. Subsequently to the submission of this work, it has been published, and copies of that paper are demonstrated here as well. Thank you.